To start off the questions, Guy, we have one for you. With the R334W variant now being eligible for Alyftrek, how do you think this will change with potassium channel modulators compared to ETI?
I'm not completely sure that I understand that question. What I suspect will happen with 334W now, it looks like, it's quite controversial now, it looks like patients with that mutation will benefit from ETI. My guess is that will be the route that they will go down. But if people do have adverse, reactions, then maybe potassium channel modulators will, in the future, be a way for them to go. But there haven't been trials in CF of potassium channel modulators, so that's a big sticking point.
Will the modulator augment the effect of Alyftrek then?
Oh,
Your K-channel modulator will.
I would think so. We could, easily test that, but we haven't.
Okay, thank you.
Maybe I can.
Yeah, Margarida, please come in.
Yeah. We have actually looked into these variants by ETI in multiple donors, and we also have, and this is actually published, and we also looked at the clinical improvement, and what was observed is we did see variability among donors. So maybe that the potassium channel additive could be used for those who respond less.
Yeah, good point. Okay. Rebecca, a question for you. At what age would you usually start taking Ascent, and what might this look like in younger children? So I think you touched upon it, but maybe...
So I think that probably 6 is a reasonable age to start thinking about it, but in a very basic form. I think younger than that, they just don't have the cognitive ability to understand what they're consenting to or not assenting to or not assenting to. But from the age, probably about 11 or 12 upwards, you'd want to be explaining on a more detailed level, and certainly teenagers are very, very much aware of what's going on and have a right to have a say about what is going on. So it needs to be done. I think that's why you need to have people involved in these trials who are experienced in dealing with children, because the way that you would talk to a 6-year-old, even if you have the same form and piece of paper for a 6-year-old to an 11-year-old, that's commonly how it is, 6 to 11-year-olds. And so you may be asking them to fill in the same form, but the way that you would approach that and talk to them is going to differ depending on their age and their engagement with you. And you'll have some kind of 7, 8-year-olds who are engaged and will be listening to you and asking questions, and some who will carry on colouring or watching their TV, and it's difficult to get them. They're just not particularly engaged, not particularly interested. And so it needs to be judged by what is appropriate for that individual. But yes, certainly not under 6, I wouldn't have thought.
Okay. My question. I had a question there, and it's moved off my screen. I had a question for you, Mike, and I think it was about how obviously there's stigmatism sometimes with some of the communities, some of our ethnic communities, about being involved in research. And how would you get around that? Have you got ideas of how we could bring them into the research process better? Sorry if I haven't said that correct to whoever asked the question, but it slipped off my screen.
I think it's a really good and important question. We had a particular patient at our centre last year, a young girl who died from CF, who was both late diagnosis and from an Afro-Caribbean family, and she spent all of her life saying, I can't have CF because I'm not Caucasian. I don't think I'm the person that should be reaching out, and I think we should probably be reaching out through our PPE network to these patients directly to help understand their views and understand what their barriers and understanding of the condition are, to try and work through those.
Thank you. I know when we're teaching now, when we're talking about CF, we talk about it as more of a global disease and in different communities, not just what we've always considered to be a Caucasian population, for example. Thank you for that. back to Guy, and perhaps also Margarida. To Guy first, can we interrogate health records to find people with CF who have also had conditions eligible for clinical potassium modulators? And could we use RWE to track lung responses to dual modulation?
That's an interesting question. But I can't answer it. I think that's maybe a question for people who have those registries. I'm not sure how you would do that, because I don't think there's actually enough clinical data, because these modulators, they've passed phase 1 and phase 2, but the data in humans is actually very limited. So I think it would be difficult to tell from registries. I can't think of how you would do that. If you're looking at their sort of genetic background, you may look at people. I mean, people who just respond badly. That would be the easiest way to do it, I think.
I agree.
And just following on from that, for both of you, do you think ASLPH is important in your studies when you're looking for new modulators? There's a specific question about what does go slow do to ASLPH, but maybe also Margarida's modulators as well.
Well,
Are you looking at that?
As part of this project, among the multiple things that we will have to validate or assess before defining a good drug candidate, is looking into how pH is actually modified. And that's going to be, I don't know if you want to add anything, Mike, but that's going to be part of the work to be carried out in Newcastle.
Yes, definitely. So we will be looking at that, how the modulators affect the response of PTC compounds as well. So definitely that's on the cards.
It's on the to-do list.
It's on the to-do list.
Oh, sorry. Yes, I forgot. You didn't hear that. Yes, definitely we will be looking at effect on pH. It's one of the parts of the work packages. We're actually, I'm typing away because I've got interviews next week for a postdoc for that position. I just had a few complications have just come in, that's why I'm not listening properly. But yes, we will definitely be doing that, and it's something that and these will be in primary, fully differentiated airway cells, and we can make dynamic measurements of changes in ASL pH. So it's an important aspect, which I think most people now are aware of, the importance of pH. As well as fluid secretion. Yeah. So yes, thank you.
So do you agree with that, Guy, as well? You're looking at pH.
Yeah, I would actually give the same answer. Watch this space. So we are planning to measure pH. We haven't done it to look at pH changes. We've set up a system where we can oscillate the CO2 levels as you would in normal breathing, but we have yet to look at what effect these modulators have on that.
Thank you. So I'm going to come back to you, Mike. There's two questions here, but I think I can probably combine them. The first one is, how can we share experience and learn from other disease areas when refining remote study designs? And the other one is, do you think AI will have a role in translation of research literature, including PIS, to enable it to be accessible to all? Because I know there was a discussion yesterday, wasn't there, about people with CF actually using ChatGPT to get the information that they want on CF and their disease.
So I'll answer the second part first, because that sounds
Whichever you like.
easier. I think that's a really very 2025 and straightforward way to interpret or translate literature, if that's how a sponsor would find it very easy and time efficient to do. I don't really have much experience of using ChatGPT, apart from making cartoons for my mum. And I know they're not very accurate. So I think there has to be, if that is the easy way to do that sponsors choose, there has to be some form of overreading to ensure that the data is accurate and we're not giving the wrong message. Thank you to whoever asked the first question. That sounds a lot more challenging to answer. I work at a very large hospital with huge haematology and liver research institutes. I'm not sure one department knows what the other is doing and how their trials are running. Yeah. Even as a large academic health science centre, and we present and share data, I don't think there is ever discussion at a very local level of our trials. So I think that probably needs to be a bigger discussion on a much larger scale. Yeah. And if that's a sponsor level question or kind of obviously investigator level, that's possibly different avenues to answer.
Great, thank you. Coming back to you, Rebecca, do trials for children need different outcome measures?
Yeah, interesting, and I didn't go into that. And yes, they sometimes do. It will depend on the outcome measure and whether it is relevant to the paediatric population. So when you were looking at, the ETI trials, when you're looking at a reduction in sweat chloride, well, that's universal across the board. But we know that spirometry is not sensitive enough. The children's lungs are too healthy for FEV1 to be a good outcome measure. We're looking at other outcome measures, which will come along, but also additional outcome measures as well. So some of the new ETI trials and enhance kind of a population study, we're looking at fecal elastase. Well, that's not something that's going to be relevant, I wouldn't have thought, to the adult population, but it's really relevant to the paediatric population. So we need to consider not just are the outcome measures, are they relevant because children are too well, but actually what impact are these medications going to have or other things going to have that are relevant to children that aren't relevant to the adult population. I think that LCI is doing is good. Looking at that compared to spirometry is good. We heard yesterday about MRI measurements. That's obviously a good way of measuring chest. We're worried about too much radiation for children, so I think that MRI will be more useful as it goes along. But we do need to consider are the outcome measures applicable, or do we need different ones?
Thank you. So I have loads of questions here, but I'm going to ask one last question to Margarida. Do the premature stop codons exist in place of amino acids which are important for CFTR protein folding? If you manage to find drugs which allow for read-through, will the CFTR protein function normally once it's been produced?
Yeah, that's a really very good point. So in our screens, I went very quickly, but we do have a flag tag in the construct which allows us to determine whether the protein reaches the cell surface. Of course, that's, let's say, an early test, because eventually what we test is the effect on function. So even if it's the wrong amino acid, but if the protein functions as it should, I think it really doesn't matter.
Yeah, great. So there are more questions. We'll try and see how we might be able to get these to you, but I really want to thank you all for your contributions this afternoon, and I hope the audience are happy with all the questions and answers they've seen, and please thank our speakers for this afternoon.